way?
Yes, that sounds good. So hello everyone, welcome to our 53rd virtual shadowing session. Tonight's session we have a specialty spotlight in sports medicine with Dr. O. All right, next slide. Here's our virtual shadowing working group. We have Reagan, Cheyenne, Taylor, Rachel, Miriam, myself, Ali, Ani, Rohit, Kiana, and then we have Dr. Fowler, Dr. Morchetti, Dr. Salazar, and Dr. Reno. Next slide. All right, here's some upcoming sessions for the month of June. We have a specialty spotlight in internal medicine on June 8th. We have a specialty spotlight in radiology on June 15th. We have a PA spotlight in dermatology on June 22nd. And we have a nursing spotlight in medical surgery on June 29th. So stay tuned. Okay, next slide. And if you have any questions, feel free to put it in the chat as we go along. We will have 2 Q&A sessions, one in the middle and one at the very end. All right, I know Rachel has a few announcements, so take it away.
Thank you so much. So guys, it's been about a year since virtual shadowing started, and it's been a crazy one. We've had 53 sessions. This is our 53rd, and we are so happy for all of you guys to join us, and we're honored that you've been part of our program, whether it be from the very beginning to just a few weeks ago, you just joined us, and we want to give back to y'all. We want to be able to help you on your pre-health journey. So we're giving out a contest to have mock interviews with our very own Dr. Fowler and Dr. Wynn, who is also a seasoned admission committee member, to help you navigate the whole Zoom online virtual interview. So we'll be having this contest starting tomorrow, and we'll send out information via email. But this contest is held over Google Forms and Instagram. Over Google Forms, all you have to do is just fill out a form with your name, email, a backup email, and telling us what your favorite virtual shadowing session has been so far. And over Instagram, just follow us on Instagram, like our anniversary post, comment and tag a friend, and comment what your favorite virtual shadowing session has been so far. Simple as that. We'll have this contest open for 2 weeks, and we'll announce the winner the Friday after it closes. So good luck, and I hope you guys get the mock interview. It'll be a private mock interview, you guys, so no worries, it won't be a live session. So Dr. Fowler, I think that you have a couple more words.
So Rachel, you say you don't think that anybody would want to do an interview live in front of 300 or 400 people. Is that what you're saying?
I don't know. I wouldn't. I'm sorry, Dr. Fowler. I love you and I love the virtual shadowing members, but I don't think I would want to do that.
If somebody is brave enough out there to do a live interview in front of the entire virtual shadowing thing, put your name, volunteer in chat. Let's see if you have the courage to do that. Anyway, let's keep moving. Trevor says he will. Okay. Oh, wait, we got a bunch that says they would do that. All right, welcome everybody. It's so good to have you back. Today celebrates the beginning of our second year of virtual shadowing. We are astonished how quickly this year has gone by, this terrible tragedy. 595,000 Americans alone have perished from a brand new disease that was not present here on Earth at the beginning of last year. And so this has been an absolutely extraordinary time. And so what we did as a working group, all of them on the call tonight with us, the working group, is that we pulled together to say, how could we best help the student preparing for a healthcare career? And we figured we would bring physicians, PAs, NPs, and other interested parties straight to you for free so that you could have an opportunity to ask questions and see what people do. You're going to love this session tonight. Dr. Ahanaja is just terrific, and he's going to give you some stuff that'll really interest you. But we want you to know that this is now the beginning of the second year. Several of our members are going off to medical school. We're going to have to revamp the virtual shadowing working group to a significant degree. We're going to keep on going, but we need to hear from you about your interest. And if you really want us to keep going and you're going to keep participating, then we'll keep coming back. So anyway, and then one of the last thing, I'll shut up, Dr. O. We will be sending out an email in the next day or so to each of you, the entire virtual shadowing family, that is inviting you to get involved in a CDC, Center for Disease Control, sponsored trial called the INSPIRE trial. The purpose of the trial is to follow people who may have been infected with COVID for 18 months to see what happens with their lives, with their medical conditions and so forth. To be involved, you have to be 18 or older. You have to have had some sort of symptoms that could be compatible with COVID within the last 42 days, for which you had a test done for COVID, positive or negative. This is for the this is for the 50 United States only. I tried to expand it to all members of the virtual shadowing family all across the 36 nations. We're still working on that. But you had to have been tested. Even if you were negative, up to about 25% of negatives will be selected for the trial. There is some money up to about $100 for participating, and all you will have to do is answer an email about once every 3 months about what your current condition is and so forth. So I want to let you know that we'll be sending you an email. Please, and please click on the University of Texas Southwestern to participate with us. It'll all be obvious in the email. We would love to have you join if you've been someone with COVID symptoms in the last 6 weeks who had a test, positive or negative. Look for an email from Rachel in the group. With that, Elena, I'll turn it back over to you to introduce our host for the evening.
Yes, well, I think we are all very excited to hear what Dr. O has to say, so I will give it to you, and we're all ready.
Great, thank you, everybody, for inviting me here to present this topic. And as everybody knows, today I will be talking about sports medicine. Particularly, my presentation deals with case study series in sports medicine, talking about different diagnosis and treatment of sports medicine injuries in the outpatient setting. Now, there are several objectives that I really wanted to get out of this presentation. Mainly, I wanted to get people to understand what goes into the pre-participation examination. Mainly within high school athletes, there's a process that we as physicians in sports medicine like to screen athletes for, just to make sure that there are no particular comorbid conditions or medical conditions that can severely impact their performance or cause any type of fatality. So we're going to talk about that. We're also going to talk about different sports medicine related injuries, their rates, their epidemiologies, and also we're going to talk a little bit more about the most common injuries and their treatments. So now we're talking about the PPE. So the PPE is something that's very, very vital for the sports medicine physician in the outpatient setting. Mainly for the PPE, when you have an high school athletes, you know, I'm assuming a lot of y'all are in Texas from the virtual shadowing working group. When I grew up in Texas in high school, the PPE was definitely something that was very vital for a lot of athletes who particularly were playing different sports that required physical. So for the PPE, it gave some people access to an entry point into the healthcare system. A lot of the pediatric population or the high school or adolescent population don't usually go to the physician regularly, but this is a very, very, very key serving point for people to get into the healthcare system, because from this venue, we can screen them and we can kind of see what their particular health status is and any type of conditions that they need to be treated for. So in addition to this, it also gives us just an opportunity to kind of talk about health and sports medicine, and also different injuries and illnesses that are encountered in the most common sports medicine cases. So when we talk about the PPE, there's several different causes for somebody being restricted from participating in a particular athletic event or sport. When we look at the statistics in epidemiology, about 53% is contributed to medical reasons. A lot of those are particular heart conditions. 47% are due to musculoskeletal conditions, and then you have this 20% that due to cardiovascular abnormalities. So elevated blood pressure is actually the most common cardiovascular abnormality found during the PPE. Now, when I'm talking about this during this presentation, I'm gonna be stating a lot of different facts, but I only want you to focus on what's most common, because there's a lot of different epidemiology about different rates, what's, what occurs with this injury. But for your purposes, I'm trying to keep this simplified. So when I'm talking about different epidemiology of different conditions, I just want you to focus on what's most common. And elevated blood pressure is the most common cardiovascular abnormality found during the pre-participation exam. So in the outpatient setting, there's different recommendations, and these recommendations that I'm giving through the presentation are largely based upon the AAFP recommendations for the PPE. So for the PPE should occur about 6 weeks prior to an athlete participating in a sporting event, particularly if they're about to start the season. That's a really good time. And this is a really good time to start initiating questions regarding any particular symptoms that they may be having, maybe some exertional shortness of breath, maybe if they have, you did a physical exam, they found a heart murmur, different conditions such as Marfan's. And as I mentioned, with elevated blood pressure, different things need to be accounted for. But for athletes their blood pressure is less than 160 for their systolic and less than 100 for the diastolic, they should not be restricted from participation. And another point we want to make note of is that athletes with well-controlled asthma, particularly if they don't have any type of symptoms at rest or exertion, they can safely participate in it and performing any of the athletic activities. I know in some countries, screening for blood and urine tests are usually initiated for pre-participation, but as far as, based on US guidelines over here with the AAFP, screening for blood and urine tests are not recommended for asymptomatic athletes. And usually whenever an athlete goes and they're getting their PPE, the physician has what we call the 14-point element for cardiovascular screening. And this kind of checklist kind of goes through asking the patient about their particular personal history. Are they having any chest pain? Are they having any tightness? Their family history. Do they have any history of anybody who died unexpectedly from maybe a heart attack or an arrhythmia? And when we do the physical exam, we look for particular things. Mainly, we look for whether or not they have any heart murmurs, right? And we also check their pulses, and we do a physical exam to check for different, physical or habitus abnormalities. And I'm not sure if anybody's familiar with it, but there's a really common, or it's not very common, but there's a condition that we look for called Marion Syndrome that can sometimes appear within athletes, and it's becoming more and more screened for, and we gotten to the point to where we have it based upon a point system. So Marfan syndrome, we'll talk a little bit more about that. And another point I want to mention why this 14-point element system is very, very important is that in Europe, compared to what we do here in the US. Europe has a little bit of a different standard on how they look at the epidemiology of what's affecting their athletes in terms of cardiovascular risk. For them, they feel like there's a higher proportion of cardiovascular abnormalities that are occurring within their athletes. For them, they use the EKG. So this became a point of contention over the last several years, whether or not the EKG should be used in screening for the PPE. So based upon the US epidemiology over here, we do not use an EKG to screen in the PPE. It's not recommended. But what is recommended is to use this 14-point cardiovascular screening checklist. And this kind of just gives us a synopsis of what we need to be focusing on in terms of like their patient's history, and gives us a little bit better idea of the main conditions that we need to be looking for based upon our research. So I know a lot of people don't like questions, but I feel like these MCQs that I've put in here kind of illustrate really good some of the points that I want to make about some of the conditions that I'm going to be talking about. And I'm going to read this question and give everybody some time to put in their answers into the chat, and then we can discuss them. So the first question is, examination findings of a 17-year-old male athlete with near syncope and suspicion for hypertrophic cardiomyopathy would include the following. Would it be A, a machinery-like murmur at the left upper sternal border, B, a holosystolic murmur at the left sternal border with a thrill, or C, a crescendo decrescendo systolic murmur at the left sternal border that decreases with Valsalva, and D, a crescendo decrescendo systolic murmur at the left sternal border that increases with Valsalva. And I want to make sure that everybody knows that these are very, very common things that we can encounter in the outpatient setting with sports medicine, and these are actually very, very high yield board review questions in sports medicine. So if you can get it, then more power to you, but I'll give you some time to think about it and put your answers into the chat.
Casey, we got some great answers. One of them was, I put D because everybody else did.
Okay, let's see. We have a few. You have some discrepancies. It's between, I'm seeing a lot of C's and D's. Okay. Give everybody about 15 more seconds. Really want you to think about this. I don't know. Well, try to take your best educated guess. All right, I'm seeing here what is Valsalva. Okay. And initially, this is why I think in the beginning of the presentation, I wanted to get an idea of if people understood what their understanding was of sports medicine. And I'm understanding that everybody here is at different levels. So some of the terminology and the answers might not be very apparent to what they mean. So I can go over them. All right, so I'm just going to go ahead and let you know the answer. So the answer to this question is actually D. All right, so it's a crescendo decrescendo systolic murmur at the left sternal border that increases with Valsalva. Okay, so to break this down, whenever you have a heart murmur, right, particularly, or a heartbeat, you have the systolic phase, right? So the systolic phase is the phase of the heartbeat that is pumping the blood. And with hypertrophic cardiomyopathy, well, when you have a increase in the heart musculature and that pressure, when there's a blockage of the blood flow that's trying to go through the heart. So what you have is a crescendo, like a high-pitched noise that then goes to a decrescendo to a low-pitched noise during that systolic phase, and it occurs at the left sternal border. And Valsalva is basically a movement where you can think about, okay, if you're holding your breath and breathing down, or maybe even straining, that's a Valsalva, and it increases with Valsalva. So that's what hypertrophic cardiomyopathy is, and good job for all those who got that answer correctly. So in terms of the distribution of cardiovascular causes of sudden death in young competitive athletes, and when I'm talking about young competitive athletes, I'm talking about those who are under the age 35. The most common cause of cardiovascular death is hypertrophic cardiomyopathy. This is very, very important. It's the leading cause of death in patients in this age group. And I'm going to ask people what they think is the most common cause of sudden death in the age group of people 35 and older. Does anybody want to go ahead and put that in the chat to try to take a guess? Okay, I'm seeing a lot of CVD, CAD, STEMI, myocardial infarction, high cholesterol, CAD. Okay, all right. So yeah, the correct answer is actually coronary artery disease. So for patients above the age of 35, coronary artery disease is the leading cause of sudden cardiac death. And for those in the age group of less than 35 and competitive athletes, it's hypertrophic cardiomyopathy. So hypertrophic cardiomyopathy is an inherited autosomal dominant trait with variable penetrance. So what that means is, for those who haven't taken genetics, an autosomal dominant trait is a trait that when inherited compared to a recessive trait, it always will manifest itself in some sort of form. So if one parent has, you receive a recessive trait from one parent, and then you receive the dominant trait from another parent, that dominant trait will show through in that offspring. When they're talking about variable penetrance, for example, if you have a patient who you highly suspect that they might have hypertrophic cardiomyopathy or might be predisposed due to family history, you do a screening on them, and they're about 10 years old, and the screening comes back negative. And sometimes with some condition with variable penetrance, if you screen for it at a later time, it will manifest itself at that time. So you can have a patient who's 10 years old, they have a very, very strong history of family history of hypertrophic cardiomyopathy, and you want to try to track and see if they screen for them if they have this trait. You do a physical exam on them, and they don't have any signs of any type of murmurs, and you come back about 7 years later, they're playing a sport, maybe basketball, they get to a point where they really exert themselves, dehydrate themselves, and they pass out on the court. And then, everybody's wondering, okay, what's going on? There's no sort of heart murmur that we discovered, a few years ago. And then at that time, they do a little bit more workup and they find out that they have hypertrophic cardiomyopathy. And that's because this condition presents itself with variable penetrance. So like we stated before, it's a harsh crescendo, decrescendo systolic murmur at the left upper sternal border, and it increases with Valsalva. And the thing with EKG, 75 to 95% will have an abnormal 12V EKG. But the thing is with EKG, with hypertrophic cardiomyopathy, there's no particular one characteristic finding that you'll see consistent with every single case of hypertrophic cardiomyopathy with the EKG. So it's not really a good screening tool. The best diagnosis tool would be through an EKG or echocardiogram, or rather a cardiac MRI. So,
hey, Casey, explain what Valsalva is, would you?
Okay, so Valsalva, I know I tried to explain it earlier, but Valsalva is like the movement of when you're bearing down, or rather even swallowing and kind of forcing pressure down. And with hypertrophic cardiomyopathy, it increases with the Valsalva, right? So the reason why it increases with that movement is that's going to decrease the flow, the preload through the heart, and that will increase the amount of murmur that's going through that heart, because with hypertrophic cardiomyopathy, the musculature of the heart compresses against the valve, and it causes that murmur to block the blood flow.
Hey, Casey, let me take a stab at one thing, if you don't mind.
Okay.
All right, everybody on the call tonight, all 300 of you, take a deep breath and hold it, and with your mouth closed, bear down like this. Do it for a few seconds. Please don't pass out. That is called Valsalva. Now, the heart is a pump. It pumps out, in the average sized person, about 5 quarts a minute. This is of an adult and your age and above, which means it has to do intake because it's a pump. Think piston, which means it pulls back 5 quarts of blood a month. Now take a deep breath and just do this. When you do that, it makes the inside of your chest cavity, your thoracic cavity, more negative, pulling blood back to it. When you Valsalva, that prevents blood from coming back to the heart. When that happens, the heart shrinks. And when the heart shrinks, especially the left side of the heart, because there's less blood is getting back to the heart, that causes the thickened center of the heart, the septum, where the thickening is in hypertrophic cardiomyopathy. And when that happens, less blood gets back, so the left ventricle becomes smaller. And as Casey said, Dr. Rose said, that then causes the obstruction to be greater in this one setting in the heart. When that obstruction is greater, the murmur is louder. How did I do, Casey?
Perfect explanation. I mean, the only other explanation I could try to give to everybody is like, try to think about if you're on the toilet trying to bear down, you're trying to like really strain. I mean, that's also another demonstration of like a Valsalva movement, if that makes any more sense to anybody else, but you explained it perfectly. Thank you. Does anybody have any more questions about explanation about any terminology?
So why are they more likely to drop dead?
Why are they more likely to drop dead? Okay,
yeah.
so
yeah.
Okay, so yeah, so these patients are more likely to drop dead is because with hypertrophic cardiomyopathy, the heart is very much dependent on preload. So they need to make sure that they have constant blood supply going through that heart. And because of that increased symptom, if they're dehydrated or overexerted, that puts them at a very, very high risk of them having a cardiac arrest, because that increased septum of the heart is blocking the blood flow. So that's why it's very, very important for them to make sure that they're monitoring their exertion and also getting medical treatment.
You know, this is it is because this is HCM, hypertrophic cardiomyopathy. Used to be called hypertrophic subaortic stenosis, or HOCM. And this is the main reason, everybody who's listening, why we put automated defibrillators, AEDs, in high schools, is so that 15-year-old kids who are 6'2" playing basketball, who look perfectly fine, drop dead suddenly because of a cardiac arrhythmia on the court. And in that setting, an AED, an automated defibrillator, is life-saving, right, Casey?
It is life-saving, yes, yeah, definitely, for sure. So the AED, before the innovation of the AED, there were several cardiac abnormalities that happened within the world of sports medicine that were pretty much fatal. But with the incoming use of the AED, a lot of these conditions have become more treatable. And one of them I'll talk about a little bit more. It's also very common in the baseball sport. So does anybody, if there's anybody needs any more explanations on any terminology, just let me know right now, and we can make sure everybody's on the same page.
This is great. Keep rolling.
Okay, great. So, you might ask, we talked about the AED, but before we even jump into trying to use an AED on these patients, there's something that we try to do. Sometimes people in the outpatient setting, they might refer to a cardiologist, but one thing we can do is use a medication, and it's called a beta blocker. Beta blocker is a medication that works on the beta receptor of your heart or your cardiovascular system to control your heart rate. And it also secondarily helps control your blood pressure. And there's different beta blockers that are used, but this is the first line medication that we try to use for controlling hypertrophic cardiomyopathy. Now, as I mentioned about other conditions that are pretty much now very treatable with the occurrence of the AED and the use of the AED in the outpatient setting. One of them is called Comico Quartus, and this is actually pretty common if you go to certain settings. Maybe you go to a little league baseball game. You have a pitcher at the mound. He throws a pitch. Somebody hits a line drive. It hits him straight in the chest, and all of a sudden he collapses. And the Comico Quartus is basically a condition where blunt chest trauma occurs, and it hits the chest in a particular area, particularly like in the precordial area, and causes an arrhythmia. And that can be fatal if not treated very soon. But before we used AEDs, this was something that caused a lot some death in especially baseball. But now that we use the AED, there's increased survival time with early defibrillation. If we can get them with a defibrillator in less than 3 minutes, then we can prevent them from going into what we call VTAC, where the heart kind of just starts to quiver. And if VTAC isn't controlled, it goes into ventricular fibrillation, which can lead to cardiac arrest. So the main important thing is that this is caused by blunt chest trauma. And it happens during a very, very vulnerable time of the cardiac cycle. So, one thing that hasn't been shown to be very effective in preventing this from happening is chest protectors. But, fortunately, we do have the use of AEDs that can be life-saving in this condition.
So, Casey, you're saying on that slide on Comico Quartus that you can get hit in the chest so hard that it'll make your heart fibrillate and have cardiac arrest.
That is correct.
Wow, that's pretty scary.
It is very scary. Yeah. And, it's something that, especially in baseball with the younger age adolescent population, some coaches aren't very aware of. So, but fortunately, if they're educated about it and there's proper medical equipment and medical personnel on board, then it can be very life-saving. But yes, this is definitely something that's, possible. You can have a really, really like hard line drive baseball hit your chest, and if it hits the right area, then that can be very, very fatal for your heart. So
well, now let's see here. Football players get stuck with a helmet right in the chest all the time. How come they don't have cardiac arrest?
I would have to say it's more so about the force of the impact, and compared from like a baseball to a football. And with football players, you also have the chest protection, and even though chest protectors haven't shown to be prevented for that, but I would just have to say that with the baseballs, it's the degree of impact and the precision of where it can hit on your chest wall that can cause a little bit more damage to your cardiac cycle.
Yeah, I think it probably has a lot to do with pads too, because the overall momentum is, I don't know what a baseball weighs, 4 ounces maybe, and at 100 miles an hour versus a 280-pound hoss, hitting you helmet on sternum. I would imagine the pads have a lot to do with it, don't you think?
Oh yeah, I would definitely say for sure.
This is great. Keep rolling. I'm sorry to interrupt, but you're doing such a great job. I just want to make sure everybody's getting the terms.
Oh yeah, no problem. So moving on to Marfan syndrome, and this is the particular syndrome I was talking about before. It's autosomal dominant connective tissue disease, and if you've ever seen somebody with Marfan syndrome, once you see one person with Marfan syndrome, and multiple patients with Marfan syndrome, it becomes easily more recognizable from patient to patient, and because they have a very, very characteristic look. They'll be very, very tall. Sometimes they'll have hyperextensible joints. They can have anterior chest wall deformities. And one of the main features of Marfan syndrome is that they have their arm span is greater than their height. So you can see somebody with Marfan's will have very, very long arms. And if they stretched them out from side to side, it would be greater than their height in total. But for Marfan syndrome, one of the things that we try to screen for is we want to make sure that they, there's no complications within their heart, because Marfan's patients can be predisposed to different conditions related to their aorta, from the aortic dilation or an aortic dissection, where basically an aortic dissection is the aorta, the valve of the heart, can kind of basically, due to the pressure and hypertension, can rupture, and blood flow can spill into the chest cavity. So that's a very, very serious complication that can happen with Marfan syndrome. Another one can be spontaneous pneumothorax. So if you have a patient, especially, you can say, they're playing basketball, you have an adolescent, and they come off the court, they're very, very short of breath, they have a really tight feeling in their chest, and then they're rushed to the ED. The ED personnel looks at them, they do a chest x-ray, they see that there's a pneumothorax, and they insert a chest tube. More than likely, there's going to be at that time a possible suspicion of Marfan syndrome with that patient. And another complication that Marfan's patients can have is something called lens dislocation. So, and that's also another serious complication that they can be predisposed to. So with them, we want to make sure that we're doing a very thorough physical exam. And if there's a high suspicion, I actually had a patient like this about a few weeks ago in our own clinic over here. And I ordered an echocardiogram. So with the echocardiogram, you'll have about 95% abnormalities. And if you want to screen them for any type of eye abnormalities, you use what's called a slit lamp exam. And another condition that we want to also make sure that we screen for in the PPE is called the exercise-induced bronchospasm. There's a lot of athletes out there that sometimes, they can have signs and symptoms of bronchospasm or asthma-like attacks only when they're exercise. And we diagnose that with something called the change in the FEV1. So the FEV1 is basically the force of how much your lungs can expire in 1 second. So from the baseline to the lowest level within 30 minutes post-exercise. So if that decreases greater than 10%, then that's when we diagnose an exercise-induced bronchospasm. So if the FEV1 is 10 to 24%, then we consider that a very, very mild exercise-induced bronchospasm. If it's 25 to 50, it's very moderate. If it's greater than 50, it's very severe. So we try to tell our athletes to manage that with making sure that they're warming up. And if they need to, you can use a SABA, which is a short-acting beta agonist or inhaler, 15 minutes prior to exercise. If the inhaler is needed daily, then what we usually try to do in the outpatient setting is add a daily inhaled corticosteroid, because that just lowers the inflammation within their lungs. And we can use also these other types of medication from a leukotriene receptor antagonist or a mast cell stabilizer. But long-acting beta agonists are not recommended. They haven't really showed any type of efficacy for treating exercise-induced bronchospasm. So the mainstay is just using the short-acting beta agonist, or the inhaler that we can think about is albuterol, if everybody's familiar with that.
Hey, Casey, what do you suppose causes EID, exercise-induced EIB? I mean, exercise-induced bronchospasm. Is that a genetic thing, or is it environmental? I dated a gal once who had to quit running track. It was really good because she would really start wheezing when she really started pushing it real hard. What causes that?
Well, as far as exercise-induced bronchospasm, I'm not exactly sure, but I know that for asthma in general, it's multifactorial. It can be, if you have a family history of it, that can be a contributing factor. It can also have some environmental contributions to asthma from exposure to pollutants, even exposure to cigarette smoke from a young age. But as far as exercise-induced bronchospasm specifically, I'm not particularly sure, but I would assume that it can have some of the relations to the causal factors of asthma.
I'm looking it up at the moment, and it seems like it has to do in part with the airways getting dried out and becoming irritated during exercise.
Yes.
And that for some reason you might get bronchoconstriction when that occurs and I don't, or vice versa. Okay. Anyway, that's interesting. Good question.
Yeah.
Keep rolling. You're doing great.
Okay, no problem. So for the next condition we're talking about is infectious mononucleosis. And as everybody knows, this is called mono, or the kissing disease. And this is actually something that's very common within the high school population. And we usually diagnose this by something called Hoagland's criteria. we took, we do a blood test, and if there's 50% lymphocytes, 10% that are atypical in the presence of, the patient having a fever, pharyngitis, sore throat, or adenopathy, and it's conferred by serological testing, then that's when we know that they do have, in fact, mono. But the main important thing for us when we're having a patient, especially in the adolescent population, is we're really concerned about them having a high risk of splenic rupture, because this can occur in about 0.1 to 0.5%, and the population in the first 3 weeks. So if you have a patient who is diagnosed with mono, from that time, you want to make sure that they're avoiding all contact sports, because any particular hit to the stomach, especially if they're playing football, can predispose them to having splenic rupture, because within mono you have splenomegaly. Another complication they can have is liver lacerations or ruptures, but splenomegaly is definitely the more common complication that they can have within the first 3 weeks of having mono. So basically, we want to make sure that they fully return to play when they're only fully asymptomatic and after 21 days of their diagnosis. And also, we need to make sure that there's no organomegaly present. So on physical exam, there's no signs of any type of splenomegaly or hepatomegaly, which is the liver swelling. Then we can be certain for sure that they are cleared to play. And here we have another question. So let's see. All right. So
is the term overweight Lyman, isn't that an oxymoron or something?
At the high school level, you never know.
You never know.
You never know. So for this question, it's saying you are the team physician at an early preseason practice when a 17-year-old male stumbles off the field late in the practice. He is an overweight lineman. He appears fatigued and is sweating profusely. He's clumsy and mumbling incoherently. The trainer takes an oral temperature that's about 102.1 degrees Fahrenheit. The defining characteristic distinguishing between heat exhaustion and heat stroke is which of the following? And this is actually something that when I was playing football, high school football in Texas, happened quite frequently, especially during spring and summer days and two-a-days. So this is something that's very high yield. Okay, I'm getting a lot of A's, few B's. Seems a lot of A's.
Got a lot of A's.
Got a lot of A's. Okay. Got one D, few D's. All right, I'm going to give everybody 15 more seconds. D's, 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 A's, A and D. Somebody said A, D, and B. Okay.
No cheating.
One answer. It's only one answer.
All right.
All right. So the correct answer is actually B. So mental status changes. That's the defining characteristic that distinguishes between heat exhaustion and heat stroke. Okay. So basically, you'll have heat cramps and heat syncope and heat exhaustion. So it's a spectrum. With that, you have fatigue and CNS dysfunction with heat stroke, right? And hyperthermia is can be from temperatures greater than 104 degrees. But with heat exhaustion, there's no CNS involvement, meaning there's no mental status changes.
A good point being, always beware the suddenly confused athlete. Something is wrong with that person. Get them down, get them out of the sun. You're about to talk about these things, but there is something wrong with them. So you need to get them in care in a hurry.
Yeah, definitely, for sure, because you only have limited amount of time when they start to have mental status changes and they're being seeming confused and stumbling, and that's when you have to act really fast. And so the best way to measure the temperature, unfortunately, is do a rectal temperature. And when you're out there in the field and you have a patient, he's stumbling and being incoherent, and you're suspecting them having this heat stroke, you have to act fast. Don't ask too many questions. You have the thermometer there. You're just gonna have to stick it in their rectum. It might not be pleasant for them. They might not enjoy it, but it just, don't ask too many questions because that could delay. So, but this is a spectrum disorder. It usually involves dehydration and profuse sweating. So there's a lot of different factors that kind of predispose a patient from to having heat illness. They could just be dehydrated. They're not drinking enough fluids. They're not having the right type of nutrition, or they might be obese. They might be using some sort of stimulants, or they might have some sort of medical condition that predisposes them to having heat illness. One example is sickle cell trait. And the best way to manage that is by removing them from the exercise, and you want to cool them and hydrate them. And by cooling them, you want to do that by immersing them in a ice water bath. So that's the best and preferred way for them to cool down. And if you don't do that in time, then they can obviously have CNS changes and rhabdomyolysis, which is basically the breakdown of muscles. And they're also predisposed to having cardiac arrhythmias.
This is a desperately, terribly serious illness. It can happen to any age group. It can be a baby in a car. It can be old Aunt Minnie who is sitting out in the sun, after church, and wearing some fairly tight fit clothing and so forth. So if you see a group of people or someone who is working out and they suddenly seem to get confused and maybe stumbling around, get them to help in a hurry. Get them flat, loosen their clothes, get them out of the sun. There are ways to cool them down, and so on. But this is a critical thing for our folks, all 400 that are listening right now, to hear. Casey.
Yes, it definitely is. It's definitely something that happens a lot. And as we're getting into the summer months, and especially in the more warmer states, you're going to see this a lot. So it's best to act fast, know what to do. Ice water immersion is the best and preferred treatment for cooling them down. And you want to make sure that if you are a sports medicine personnel, making sure that the athletes are staying hydrated. You have the proper equipment there, and making sure that if you are working outside in the heat, that you're properly conditioned and hydrated. So
could we respond to almost everybody picked A? Casey, I'm sorry to butt in. I hope you'll excuse me, but I'm really enjoying talking to you. We've been going almost an hour already. Can you believe it? It feels like 5 minutes, but this is a great session. It is certainly true that historically it has been said about heat stroke that the body's thermoregulatory mechanism breaks down and they stop sweating. Well, the problem with that is this: they may not stop sweating, number one, even though they're already confused and altered. And number two, it's this point, the absence of the fact that they've stopped sweating, or I should say they're still wet, still does not mean that they're not having a heat stroke. Exactly. Or to put it another way, you can be having a heat stroke and still be sweating.
Right.
Great stuff. Keep rolling. You're doing a great job.
Thank you. All right, so.
All right, here we go.
All right, so here we have another question. So which of the following statements is true regarding sports-related concussions? Is it A, return to sports can occur prior to return to baseline academics? Is it B, physical rest is recommended until all symptoms of SRC have resolved? Or is it C, physical rest is recommended during the first 24 to 48 hours post-concussion? Or is it D, the overall duration of SRC symptoms is the same in children, adolescents, and young adults? Okay, I'm seeing a B's and C's.
I like two of them.
Like two of them, okay. There's only one question, there's only one answer. But.
All right.
B, C's, B, C's. Okay. All right, 10 more seconds. All right, so seems like everybody was stuck between B or C. All right, so let's kind of go through reading both of these since everybody was kind of, stuck between these two. So B says physical rest is recommended until all symptoms of SRC have resolved. Originally, prior to more research going into this, physical rest was considered a vital part of a recovery from a concussion. However, as more research has gone into this, physical rest has only been recommended for a shorter duration of time. And we actually do encourage athletes to start doing some light activity about 24 to 48 hours post-concussion. So the correct answer for this question is actually C. Physical rest is recommended during the first 24 to 48 hours post-concussion. And then there's a gradual increase in activity and until they can return to play. So when we talk about sports-related concussions, right? As we know, concussion is just a traumatic brain injury induced by like a biomechanical force. The highest risk of having a concussion sports-wise is in contact sports, whether it be football, rugby, hockey, and soccer. And it usually happens more in terms of whenever there's competition. So whenever players are practicing, there doesn't seem to be a higher correlation of concussion because obviously there's less movement. People aren't going as hard, but whenever it comes to actual competitions and games, there's an increased risk of sports-related concussions. And this seems to be, from our research, higher in female athletes or even patients who have a prior sports-related concussions or players who have player-to-player contact like the sports I just described. So some of the most common symptoms, if you ever see a patient have a concussion, or even if you've had a concussion yourself, number one is a headache. Patients, who have a concussion, always, almost 100% of the time, going to complain of some sort of headache. They might be dizzy. They can also be confused or have some sort of foggy or disoriented mentation. But loss of consciousness only occurs about 8 to 9% of the time. And one of the more important things is that if you have a patient who has loss of consciousness with a concussion, it has to be witnessed by somebody. You just can't ask a patient like, okay, like they'll say, okay, oh, I lost consciousness. And then like, how do you can ask them like, okay, well, how do you know? Well, I just felt like I lost consciousness. Well, you ask them like, did anybody see it? And then if they said no, okay, well then, I mean, it really can't be confirmed. Somebody has to be there and actually see them lose consciousness to confirm that they did have a change in their mentation. So neuroimaging really doesn't have any very much use in evaluating a patient with SRC. So we try to avoid doing that in the peds population. For the most part, we have other modalities that we try to use for assessing a concussion. And the first assessment tool that we use is the SCAT. So the SCAT is basically an assessment tool of different questions based upon, physical exam findings, and also different findings that we see in the patient and related to their concussion. That kind of helps us grade the likelihood of them having a concussion. And so we have an SCAT-5 for adults or more of the older adolescent patients. And then we also have an SCAT-5 for the more younger population from the ages 5 to 12. Most important thing is to remember that there's no same day return to play for an athlete with a SRC. I mean, if somebody has a concussion, you can't send them back onto the field or the court to play. They do have to make sure that they are adhering to that 24 to 48 hour rest period and following up with assessment and evaluation after that. You can do neurophysiological testing to add to your assessment of the SCAT, but for the most part, the SCAT in itself can be sufficient in you diagnosing a sports-related concussion. So,
it's been interesting to watch. I've been in medicine almost 50 years, and it's been interesting to watch how concussion has become a disease that we recognize, and we really didn't many years ago. But there actually are real structural changes that occur in the brain, actual physical structures within the neurons, and that explain a great deal, and leading to such things as chronic traumatic encephalopathy and so forth. But this is such a very, very important thing, and these must be managed correctly. I would dare say that the management of concussion is one of the very important areas in sports medicine. Would you say that, Casey?
It is one of the most important areas of sports medicine, especially like you mentioned with more recent research into CTE and how that has long-term effects in changing the neurostructure of the brain and some of the long-term effects of that. So I believe that, in the past, there wasn't really a lot of focus given to concussions and their long-term effects, but it's, in my opinion, one of the most important aspects of sports medicine that needs to be paid attention to, because there's so many things that we don't know about it in terms of long-term effects, but we are learning a lot more about how some of these, injuries related to concussions can change the brain structure and how that can be detrimental to patients in the long run. So it's definitely something that needs more attention.
It's been interesting that the study of concussion has led to a lot of things in sports. For example, helmet design in football has been very significantly modified with the passing years because of the risk of concussion, number one. Number two, the rules of the sport has changed.
Exactly.
For example, what is the term, who remembers the term when somebody hits helmet on helmet? Is that called spiking? What's the term? Some of the folks in chat out there. Is targeting, is that the word? Targeting?
Yeah, targeting.
Is that what it is?
Yeah.
That it is because of concussion that targeting is no longer allowed because of the danger of head damage. Please go ahead, Casey. Great talk.
Oh, thank you. So SRC management, so the most current updated management for SRC, like I said, you have to make sure that the patient has physical and cognitive rest in the acute phase. So from about 24 to 40 hours post-injury, you want to make sure that they have like a light activity that remains below their symptom threshold. So you want to make them do something that's very light, that's not going to exacerbate their symptoms. So if they're having a headache, you don't want them to do something that's going to exacerbate the headache. They can do something like maybe a light walk, or maybe riding a stationary bike, or some sort of light activity that can get them going, but doesn't exacerbate their symptoms. And you want to make sure that they return to their academic baseline prior to returning to their play in athletics. So when an athlete can tolerate about a half an hour to 45 minutes of cognitive activity, for example, they're at home, they're reading a book, or they're doing some homework, and they can sit down for about half an hour to an hour without any headaches, feeling dizzy or fatigue, then that's an indication that they are returning to their academic baseline. And then from there, they can return to athletics. And when they return to their athletic sport, you want to make sure that they're doing so in a stepwise manner. You want to do graded program exertion prior to medical clearance and return to play. So when you have the evolution of the SRC, so about 80 to 90% of all athletes have resolution of their symptoms in 7 to 10 days after their injury. And the rate of recovery usually varies based upon different factors. In younger athletes, there seems to be a longer rate of recovery. Female genders, you have post-concussive migraines, or even having increased numbers or prior SRCs that can also affect your recovery rate. And children 5 to 12 years of age seem to have recovery in about 4 weeks, and balance usually returns to baseline 3 to 7 days after their injury, and cognitive function returns to baseline at 5 to 7 days on average in the NCAA athletes. So this is a graph kind of to illustrate and summarize SRC management. So you have the SRC symptoms, you have a patient, maybe a football player who gets a concussion in a game. He sits out, and about 24 to 48 hours, you have these symptoms. And from there, you have daily activities at home that don't aggravate his symptoms. We encourage him to, maybe do some walking, maybe a stationary bike. And then from there, he tries to, sit down and do his homework and school activities. Once he can do that with, adequate, or she can do that with adequate, adequate issue, without any adequate issues for about 30 minutes to an hour, then they can know that they're returning to their baseline. And then once they are returned to their baseline academic wise, they can try to return to their athletic performance, and do it through a graded exercise program, or a graded stepwise return to their athletic performance.
A real take home on this is that concussion actually is a disease. It's an acute traumatic illness. And the injured organ, in this case, the brain, has got to be allowed to get well. Otherwise, chronic changes can occur, which can be, in some settings, devastating or cumulative, one after the other, and so on.
Yeah, that's definitely correct. All right, so let's stop at this point. We have Q&A.
Yes, we have quite a few questions. I don't want to take up too much of your time, so I'll just go through a couple.
Okay.
One question we have is, what made you go down the sports medicine path?
Well, that's a very good question. Well, I grew up playing a lot of sports in Texas. I'm originally from Texas, the Dallas-Fort Worth area. I got very, very active into playing sports and from high school and even early college. Uh, but I also had the unfortunate um, situation where I had a few really, I guess, detrimental injuries that I had to do some rehab and recovery for. But it was during that time of doing my rehab and recovery that I kind of got a little bit more into sports medicine and learning a little bit more about it. And from there, I got more fascinated into sports medicine, and even after college did a little bit of personal training, and um, as of right now it just seems like a career that I feel like I fit into, and I have a large interest in working with athletes and kind of relating to their issues, motivating them to recover from their injuries. And it's just more of like it's a fascinating field for me, and I feel like there's a lot of things that I can bring to the table with sports medicine. And overall, it's just something that's fascinating. I feel like I can have a lot of passion for it. And with sports medicine, it's something that it's very dynamic. You can work with athletes from a lot of different sports. You can work with athletes from a lot of different age groups, and you can do so many different things in the outpatient setting, or even whether it be if you wanted just to do specific pain management, or if you wanted to work with them in strength and conditioning, or even some, adding in some lifestyle modifications to their regimen. It's pretty broad, and it can really, really take a person who has a passion about sports and kind of bring them into their own niche of whatever they're focused on. So those are some of the reasons why I really wanted to do sports medicine.
Okay, well, it sounds like you've been involved around sports like your whole life, so that helps out.
Yeah.
Another question we have is, what is your prevention advice to athletes who are at risk of chronic traumatic encephalopathy? And then what are some lifestyle consequences of those with untreated CTE from sports?
Okay, so could you repeat the first question? I'll try to take the first question first, and then I can answer the second question.
Yes. So what is your prevention advice to athletes who are at high risk of chronic traumatic encephalopathy?
Okay, so prevention advice, particularly from someone who played a high contact sport like football. If you are in a sport like that, be it football, rugby, or even sometimes even soccer, highly recommend just to protect yourself. If you're in football, making sure that you are, um, having proper form and whatever, contact that you're making on the field, making sure that you're having the proper equipment, whether it be helmets and pads, and also just making sure that you're strengthening your muscles overall to, if you are in a contact sport, that you can properly absorb shocks a little bit better. But as far as anything else, I would have to say those are the main things I would try to focus on if you are in a contact sport that predisposes you to concussions and possibly having CTE, just to protect yourself and make sure that like you're taking all the precautions to make yourself more resilient to and protected from those type of injuries.
Okay, and then to follow that question, it was, what are some lifestyle consequences of those with untreated CTE from sports?
Well, from what we know more recently from research, those with untreated CTE uh, are, susceptible to later, somewhere down the line after they're done playing, having, depression, maybe, some sort of behavioral problems, or maybe aggressive attitudes, or even just headaches or other neurological symptoms. But then again, these are things that we're just now starting to research and understand. But from my own research, those are some of the things that patients who have suffered multiple concussions or have been in high contact sports that have shown that they have had CTE are susceptible to those different conditions.
Okay. And then another question we have is, why is Comico Quartus more common in under 16-year-olds?
I would have to say, I'm not absolutely sure, but my educated guess from what we know about anatomy is before the age of 16 might have to be due to just the bone structure and bone and muscular structure. At that age, it's not 100% developed to withstand those type of impacts. So I guess in that adolescent population below 16, you would find it more often in that case because just because of anatomical and physiological differences compared to those who are a little bit more post-puberty age group. So
okay. And then another question we have is, how do you propose we educate coaches and parents on these conditions that can occur?
I believe it's just up to physicians in general and healthcare providers who are educated about these conditions to reach out to, high school, middle school, and elementary school sports groups to educate these particular populations, because we're the ones who are constantly involved in the research on this, and we can do it simply by during the PPE or reaching out to high schools for sports physicals and scheduling different sessions to educate coaches and parents about certain risk factors of their sports and things that they need to be aware of. And I feel like if we can do that, then that's a good starting point. And I believe that afterwards, more coaches and more parents will be a little bit more open to reaching out towards us and establishing a direct communication and learning more about different sports medicine conditions and things that they need to be aware of.
Okay. And I'll do one more question before you can start ahead in lecturing. How have you had to do any examinations due to COVID? And then this particular student who asked is a college athlete, and she had a heart screening after she had COVID.
So the question is, have I had to do any examinations?
Yes, due to COVID-19.
So which type of examinations?
This particular student had a heart screening, but honestly, like anything related to COVID-19.
Yeah, aside from routine H&P, histories and physicals, Casey, have you had patients as a resident that you strongly suspected were COVID and you had to do a really thorough history and physical examination on them to determine if they had any various organ dysfunction, myocarditis, for example?
Oh, yes. I've actually had several COVID patients throughout this year. I even had one this past week. A very young patient. He was only like 40 years old. Got COVID pneumonia, and we suspected myocarditis as well. But I've had several COVID patients with different manifestations and complications from COVID, whether it be COVID pneumonia, COVID induced pulmonary embolisms. So I've definitely had to do quite a few physical exams on patients who were COVID positive. So that I've seen a lot this year.
All right. Well, That's all the questions for right now. So I'll go ahead and let you start your next half of the presentation.
All right, so the next half of my presentation is going to begin with eating disorders. So athletes have a higher prevalence of eating disorders than non-athletes, and that can be from anything from anorexia or bulimia, and it's present in about 18 to 20% of female athletes and 8% of male athletes. The best thing to do in this situation is to have a team approach to management. And some of the common comorbidities that we also see in the adolescent population with athletes is depression, anxiety, OCD, and sometimes they can have even substance abuse disorder. And moving on to another condition that we also see in the outpatient setting is anterior shoulder dislocation. So this can happen in several different sports. We see it often in football, and 70% of the shoulder dislocations are usually anterior, but 90% of the anterior dislocations are usually traumatic. So shoulder instability in the young athlete is usually a result of dislocation. But sometimes, whenever a patient has a dislocation on the field and they're walking with holding their arm, there's sometimes a feeling to panic and, oh, we should rush them to the ED, we should, take them to the OR. But for the most part, the best thing to do in that situation is to reduce that dislocation right there and then. There's a few maneuvers that you can do there if you have a trained professional to reduce that dislocation back in place. And early reduction on the field and pain reduction and ease of the reduction is better if you just do it right there and then, rather than you having to take them to the OR, put them under anesthesia, and immobilization of the shoulder and the abduction and ER reduces the risk of complications. So another condition that we also we sometimes see in the outpatient setting is the femoral acetabular impingement. So basically, in this condition, you'll have a patient, they'll be walking, they'll be holding their hip on their side, and you have pain in the anterior lateral groin, and sometimes we call that the C sign. So on the physical exam, you usually have reproduction of the pain when the patient flexes their hip or they adduct, and by adducting, that means like moving their hip towards the center, or internally rotating their hip. So the best maneuver or the most sensitive exam maneuver to test for this is called the fader movement, and it's usually managed with NSAIDs and a course of physical therapy. And usually, sometimes a therapeutic injection can be helpful, but for the most part, the first line of therapy is to give the patient an NSAID, like an ibuprofen, and to make sure that they strengthen their muscles through PT. So next question that we have here says, you have been invited to present a lecture on sports injuries in high school athletes. So which of the following statements would you include in your talk? Would it be A, football has the highest injury rate? Would it be B, injury rates are higher in practice as opposed to competition? Or would it be C, the knee is the most commonly injured body part in high school athletics? Or would it be D, the anterior cruciate ligament is the most commonly reported knee injury in high school athletics? Seeing a lot of D's, B, B or D.
That's
Everybody seems.
This is a hard question.
It's actually pretty straightforward if you think about it. Everybody seems to be, or most people are lingering on C or D.
Elena says she's giving up, according to what I saw.
Oh, she shouldn't give up. Okay, so Elena's saying A. Okay. All right, so now we have some A's coming on in here. Anybody else? 5 seconds. All right, so actually, the correct answer is A. Football has the highest injury rate. Now, a lot of people were initially jumping on D. The anterior cruciate ligament is the most commonly reported knee injury in high school athletics. That is actually not true. We all hear about people tearing their ACLs and having ACL reparative surgeries, but actually the most commonly reported knee injury is the MCL. So football for sure has the highest rates of injury. So, I mean, from year to year, it changes, but it's usually a very consistent trend. You have football having the highest amounts of sports-related injuries. Sometimes people can say, okay, well, how about cheerleading? Well, cheerleading does have a lot of injuries. However, it has the most catastrophic related injuries. Those that have injuries that can predispose them to neurological conditions or paralysis or those sort of things. But in terms of overall, football in general has the highest amounts of injuries in high school sports.
Our hostess with you this evening, Elena, is a competitive soccer player in college. Elena, have you seen a lot of injuries?
Yes, I actually have. So one girl on my team actually tore her ACL for the 3rd time. So she's unfortunately done with her college career as being an athlete. So yeah, we've seen some pretty bad stuff. Luckily, I've been lucky, so I haven't been injured. Knock on wood, but there has been a lot. So
yeah.
All right, keep going.
So this is just a surveillance study also showing the same thing where football, especially in competition, like I mentioned before, in competition is usually where you have the most injuries related and compared to in practice time. And that's usually just because, we have more people going full speed, going harder, doing more plants, more cuts. And that's usually where the injuries are coming from. So in terms of the most commonly injured body parts in high school sports, you have head and face being the top, followed by the ankle and the knee. And we already talked about the concussions, but also the ankle and knee injuries are among the top 3. And as everybody was jumping on D, thinking that ACL injuries are the most common knee injuries, it's actually MCL injuries. And this is actually very, very common, particularly in football. You'll have a lot of football players from the high school to college age groups where it's particularly if you're working with linemen, they're wearing knee braces that are supposed to be protective of their MCLs. And so knee braces are actually shown to be useful for those particular position groups. But sometimes what happens is if you have like other positions like quarterbacks and running backs, they try to wear those braces, but they don't have the same efficacy in protecting them from MCL injuries. So that's one interesting thing that's been found with the research on knee bracing with football players is that with the linemen, they seem to have a little bit more protection with wearing that knee brace, but for some of the other skilled positions, they don't have that same protection, and that's why there's a larger increase of injuries with the MCL. And one thing also I wanted to mention is that with ACL, wearing a knee brace with the ACL injury or just prevent an ACL injury has not been shown to be effective in preventing or protecting the ACL. So that's just an unfortunate thing about ACL injuries. That's why they're so detrimental to those who get it. But it's not that they can't be repaired or recovered from, but it's just something that the patient or person has to keep in mind when they're doing their rehab. It's that once you have an ACL injury, it's a little bit harder to protect compared to the MCL.
Hey, Casey, we got a good question from Noel. Why do females have almost twice the occurrence of patellar tendon injuries and half the occurrence of MCL injuries? And I wonder why that. Different sports, maybe?
Different sports, I would have to say that's one contributing factor. I would have to say, yeah, it would definitely have to be the different sports and maybe even the nature of like the maybe movements in the sports. So that's a good question. I don't actually have.
That's a good question, Noel.
Yeah. So
keep rolling, doing great. Oh, here we go again.
Another question. So question 5 says, which physical exam test is the most sensitive maneuver for the corresponding knee injury? So interesting thing to note is that each knee injury in the clinic has a particular physical exam maneuver that is diagnostic for that particular knee injury, and there's several of them. Some of them even have multiple maneuvers, but usually one maneuver is more sensitive than the other. So is it A, Thessaly test for the meniscal tear, B, anterior drawer test for the posterior cruciate ligament, is it C, McMurray test for the meniscal tear, or is it D, the valgus stress test for the lateral collateral ligament?
I know this one because I've done that test many, many, many times.
Everybody's saying, oh, let's see. We got C's, A's.
There's a hint on D, which is valgus means you push the knee into the valley, into the area between the knees. That's a hint. So would that stress the medial ligament if you press the knee into the valley? Or the lateral ligament? That's what I meant to say. There's some smart kids out there. Listen to those. Elena, or did I say it right? Ashley? All right, amigo.
Yeah. So people are saying C's, but actual answer is A, the Thessaly test for meniscal tear.
I got that wrong. I thought it was McMurray was for the meniscus, but I guess I was wrong.
But it's the most sensitive maneuver.
Is the Thessaly test?
is the Thessaly test, exactly.
All right. Well, show. I don't even know that. Show us how to do that.
Yeah. So, okay. So the Thessaly test, and I will explain that. So you have best exam maneuvers for knee injuries. So for the anterior cruciate ligament, you have the Lachman test. You can also do the anterior draw, but the Lachman test is more sensitive. For the posterior cruciate ligament, you have the posterior drawer test, where you're bending the knee at the 30 degrees and pulling it back. And then for the medial collateral ligament test, you have what Dr. Fowler was hinting at, the valgus stress test. And then for the meniscal tear, you have the Thessaly maneuver. So basically, you can either do it single leg or double leg. You can have the patient bend their knees at 20 degrees. You can do it for one leg or two legs, and then you can have them swing their knees from side to side. And if they are endorsing some pain with that movement, then that's when you know that they possibly are positive for that meniscal tear. So that's the Thessaly maneuver. And you have another question. So which one of the following statements is true regarding ACL injuries? Is it A, prevention programs are ineffective at reducing ACL injuries? Is it B, bracing is effective in the secondary prevention of ACL injury? Or is it C, in high school sports, football has the highest rate of ACL injury? Or is it D, surgical repair of an ACL tear results in lower rates of knee osteoarthritis? Yeah. Howard, I already talked a little bit about this question. I don't know if you're paying attention, then you can at least rule out one of them. They got a lot of A's and D's.
You ask hard questions.
These are actually pretty straightforward questions if you think about them.
All right. What's the word?
All right. So answer is C. In high school sports, football has the highest rate of ACL injury. And that kind of just goes along with the previous question I talked about high school sports in general having overall the highest rates of injuries. So if we break this down, prevention programs are ineffective at reducing ACL injuries. Actually, prevention programs are somewhat effective at reducing ACL injuries, and I'll talk a little bit more about that and later slide. And then we have bracing is effective in the secondary prevention of ACL injury. So if you were paying attention to what I was saying before, bracing of your knee to prevent ACL injuries is not shown to be effective in secondary prevention of ACL injuries. And when we're talking about D, surgical repair of ACL tear, results in lower rates of knee osteoarthritis. Actually, research has showed that even with surgical repair of ACL tears, there are patients who years down along the line do still have signs of osteoarthritis in their knees, particularly in women. So that's what we're dealing with ACL injuries. So we look at ACL tears, the interesting thing with ACL tears, are 70% of them are usually non-contact injuries. And even in football, when you have a ACL tear, a lot of times it's because somebody is running and they plant and then their ACL gives out. So I was unfortunate to have an ACL tear when I played high school sports. It was a non-contact injury, and in football has the highest rates, like I stated before. But going back to what I was saying about the prevention, neuromuscular training reduces the risk of injury in female athletes. So a lot of some programs, I guess high school programs, are getting in contact with either gyms or physical therapy groups and using programs right before their season starts, maybe in the off season, to teach athletes how to land properly on their knees, whether in strengthen their hip flexors, strengthen their quadriceps, strengthen their calves, to reduce the risk of injury to their ACL. So that's one thing that's becoming more popular. So if you are a physician or sports medicine professional in that community, I highly recommend that you do promote this, and because it definitely will help reduce the risk of injuries, especially it's been shown in female athletes to reduce the risk of ACL tears when they're implemented properly. So like I said before, knee bracing hasn't really shown to be very effective in primary or secondary prevention of ACL injuries. And the development of osteoarthritis is similar, whether the ACL is repaired or whether it's not. So my own opinion, and also research, so if you have a patient that's maybe 15 to 16 years old, they're an athlete, they're trying to think about going on to play at the next level, and they tear their ACL, and now they're at the trying to make a decision whether they should have surgery or not. For example, if they're playing soccer or football, I would definitely highly recommend them to have their ACL repaired. But if you're dealing with a 50 to 60-year-old individual, the only thing that they do activity-wise is maybe cycling or swimming, occasional walking or fast-paced walking, not a lot of lateral movement. At that point, I would not really recommend an ACL repair, because at that point it's the ACL being more for the lateral movement, and stability wise, it wouldn't really add anything to their quality of life. So that's usually what happens when you have a patient where we have ACL. We have to look at what their outlook on life is in terms of what they're going to be doing activity wise. How much is stability going to be playing a factor into their quality of life and their daily life, and if that's something that's going to be affecting them for a long time and that they're going to be using, then ACL surgery is definitely highly recommended in that case. So this is the interesting case study that I came upon in the American Medical Society of Sports Medicine. It deals with a female athlete who had knee pain about 10 years after ACL tear. So you have a 28-year-old female who presents with a 2-month history of worsening left knee pain. Her pain worsened after a recent bicycle crash in which she fell directly on her left knee. And prior to that, she occasionally had pain with activity, but it did not limit her activity. Now she complains of lateral knee pain, 3 out of 10 at rest, and with activity, it can get to about 8 out of 10. She has buckling, locking, catching, giving away, and swelling. And prior to this acute pain, she had exercised 7 days a week. She ran 5 to 12 miles 4 to 5 days a week and played flag football. Now she has pain with even low impact exercise. Her past surgical history is notable for ACL reconstruction at age 18. Her past medical history includes 3 stress fractures in her early 20s while training for marathons. She has osteoporosis on DEXA scan and was started on teriparatide, but stopped taking it after 5 to 6 months. She's currently only taking calcium. She was referred to a nutritionist, but never followed up. And her has reported irregular menses and has not had a normal cycle in months. So from here, we did a physical exam, and the left knee shows a weld-healed surgical scar, full range of motion, no effusion, and it's notable for crepitus. And by crepitus, there's a little bit of cracking or popping sound whenever the patient is moving their knee. And when you look at the lateral joint line, there's also tenderness. And when we do the Lachman test, it's 1+ and positive McMurray's test. And she has a stable posterior drawer and a valgus and varus stress test. Her gait is anthologic with a prominent valgus deformity. So can anybody think of any differentials of what's going on right now, if anybody has any idea? Does anybody know possibly what's going on? Say an ACL, meniscal tear. Meniscal tear plus arthritis, okay. All right, so basically, some of the things that could be going on based upon just the physical exam is we have tear of our ACL graft. It could be possibly going on. You could have an acute meniscal tear. She could also have a post-traumatic osteoarthritis, even a bone contusion, or what we call the female athlete triad. So when studies were ordered, you had an X-ray of the left knee. It showed tricompartmental or osteoarthritis of the left knee with severe narrowing of the lateral compartment. So you had a 9-degree valgus deformity of the MRI of the left knee. And then for the MRI of the left knee, you have the ACL reconstruction with diminutive appearance of the graft. And then there was also a macerated tear of the residual posterior horn. So she also had some tearing going on, and as well as some degeneration of her ACL ligament. And a key finding also was that there was some severe osteoarthritis of the lateral compartment. So what happened was orthopedic surgery was consulted for evaluation for surgical options. And for the working diagnosis, they came up with a severe lateral compartment knee osteoarthritis with the valgus deformity. And she also possibly could have relative energy deficiency in sports, so the female athlete triad. So she underwent a left distal femoral osteotomy with a plate fixation, and then she had a concurrent left knee ACL revision surgery. So they basically went into her knee and they placed a plate, and then they revised her ACL ligament, and they prescribed her some physical therapy exercises to do. So, as of right now, she's doing physical therapy. Her goal is to return to running. And for their goal, they wanted her to address her bone health, her nutritional status, and overtraining, with additional goal of preserving her joint. So a main point of
Casey, what is an osteotomy?
Osteotomy. So osteotomy, femoral osteotomy is where they basically are taking part of the bone and putting a plate inside, so to secure and stabilize it.
Thank you.
Yes. Okay. Any other questions about that?
You know, it's amazing she could have this much destruction of a knee by the young age of 28 years old, for heaven's sake.
Yeah, so the main point I'm trying to make from this is that actually with patients, even after they have ACL repair, overtraining can predispose them to having this severe degeneration of their knee. So research has been showing that, you know, like even with athletes who they have a surgical repair of their ACL, they go back to playing sports, they're training really hard, but then now they're, you know, coming up with these, you know, chronic knee issues because they're overtraining. So the patient has early advanced osteoarthritis at the age of 28, which is, you know, if anybody knows about osteoarthritis, that's a very young age to have osteoarthritis. And it's due to a combination of her previous ACL tear and then interim overtraining. And because she has like really severe joint space narrowing, she wasn't a candidate for a meniscal transplant. So as of right now, she was only a candidate for an arthroplasty. And then this case also illustrates this risk of overtraining after an ACL injury, and you know, stresses that basically patients can be susceptible to having arthritis in the long run if they do overtrain. So although I did mention neuromuscular training for you know, secondary prevention as well as treatment for an ACL tear, it's also very important to stress to the patients that they should not, you know, overtrain and to moderate their exercise regimens.
You know, Casey, over the years, I did a lot of family medicine in my hometown back in the 80s and 90s. And I spent a lot of time telling people, you know, who had overtrained, I said, look, chances are the Olympics are not going to call. And so
Right.
and it's probably not going to make you live any longer in your life by getting in some kind of fabulous shape. So, you know, work out comfortably. You don't have to injure yourself to prove anything.
Mm-hmm. That is true. That's true. People unfortunately have the misconception that like, you know, the more you work out, it's gonna just keep on producing, you know, more and more returns. But you know, there's a point of diminished returns, and that's when you have overtraining, you can have complications like this. So it's very important to keep that in mind. So neuromuscular training. So I actually had opportunity to have, this is Dr. Katie Simmons. He's at the resident in Cleveland, or actually Akron, Ohio. And she was a former college basketball athlete who had a knee injury, and I had her demonstrate some examples of neuromuscular training here in the gym. These are just some lunges, and lunges are one of the more notable neuromuscular training exercises that patients can do with knee injuries. They help focus on the flexors of the knees as well as their calves and their quads. And then she's also here doing step ups. So in terms of acute knee injuries, you know, there's several different mechanisms for how these different knee injuries happen. So for the ACL tear, it's usually a hyperextension. And then for a meniscal tear, it's a twisting or fixed foot. And then for the PCL, it's either fall on the flexed knee or a dashboard injury. And for the patellar tendon, you usually have like a violent quad contraction. And then if you have like a patellar dislocation, it's usually like a flexion with valgus movement with a directional force. So we have another question here. So it says a 26-year-old male suffers an inversion ankle injury and ambulates to the ED for evaluation. You find lateral ankle swelling and tenderness over the anterior distal fibula. So the next best course of action includes A, avoidance of the use of ankle bracing after his injury resolves. B, recommendation for early range of motion for the ankle. C, avoidance of the use of NSAIDs, or D, radiographs of the ankle. Okay, a lot of people are saying D.
We X-ray everything,
In the ED, yeah.
but I know what you mean.
Right. Okay, we have a few people saying B. Get them moving. Okay. D, B. All right, so yep, actually the answer is B. So whenever you have somebody who has a acute ankle injury, the best thing for them to do is to have early range of motion, so that limits the possibility of any swelling and limiting of range of motion in their ankles. So in the outpatient setting, the thing that we have them do is have some early range of motion exercises if that person comes off the field and they have an ankle injury. That just kind of has been shown to limit prolonged complications of ankle injuries. So, and in terms of ankle injuries, lateral sprains are the most common. And the initial treatment is rest, ice, and elevation and protection. And early range of motion has been shown to improve recovery. So with ankle sprains, the clinical recommendations are you use NSAIDs to reduce pain post-injury, and also can reduce time to return to play. The most effective way to, as far as primary and secondary prevention for ankle sprains is ankle bracing, but there's other things that you can also do. Graded exercise programs and proprioceptive training are also recommended to reduce the risk of ankle sprains. And here, I also have a few more demonstrations. So this is Ray Thomas. He's a engineer and fitness expert here in Detroit. He also makes fitness equipment. And here he's also being a Brazilian Jiu-Jitsu expert, in his recovery from his ankle injury. I was demonstrating him some proprioceptive exercises with this balance board. And this exercise can be used for different sports, from skiing to soccer, or any other exercise that requires lateral movement. And it helps by strengthening your core as well as your lateral ligaments of your ankles as well. And in this slide, I also had this is a Wayne State medical student. His name is Julian Johnson. And he was also demonstrating this proprioceptive exercise where he was doing some squats on this balance ball. And so proprioceptive training has been shown to prevent ankle injury, as well as treat ankle injury after its occurrence. So you only X-ray if there is a malleolar sprain or pain in the region of the navicular or proximal fifth metatarsal. You can get a foot X-ray. And also, if there's an inability to weight bear 4 steps at exam, or there's discrete bone tenderness at any site noted. So these are the Ottawa ankle rules. So these are the rules that we use in the outpatient setting to guide whether or not we need an X-ray. So these are very important rules. It kind of, in the long run, saves us the cost of imaging, and it gives us a very quick assessment of whether or not the patient needs an X-ray at that moment in time. So another thing I wanted to talk about that's also very important in sports medicine are different impingement neuropathies. And this can happen in several different sports modalities. You can have a handlebar neuropathy, and this is very common in cyclists. And that can happen with what's called an entrapment neuropathy of the ulnar nerve, and the ulnar nerve is obviously over here on your pinky, and it happens with what is called the Guillen's canal, where the nerve travels up through the hand, and you can have paresthesias in the palmar, fifth, and ulnar aspect of the fourth digits of that affected hands. And then you can also have an ulnar neuropathy, and this happens is with a lot of baseball players, or even sometimes even quarterbacks or pitchers. You have a irritation or subluxation of the ulnar nerve at the cubital tunnel. And then you can also have numbness in the dorsal aspect of the fifth and ulnar aspect of the fourth digits of the throwing arm. Another common neuropathy is saddle neuropathy. This happens with cyclists, and they have, on their basically their pelvic region, and that's usually due to entrapment of the pudendal nerve at the narrow seat. With also another neuropathy that's very common is called the peroneal neuropathy, which happens in contact sports due to trauma on the lateral aspect of the knee or foreleg, and it's proximal fibular fracture or even a compression from a tight castor brace. So this is kind of very common in soccer players or even football players who sometimes slide, or even baseball players who are running towards a base and are sliding towards home, or football players who are getting hit from the lateral position. They'll have this numbness on the lateral aspect of their leg. So that's also one of the more common impingement neuropathies that we see in the outpatient setting. Additionally, something that we also see in the outpatient setting is skin infections. So skin infections are usually spread by direct physical contact or fomites. So if you're working with, especially different teams who are in a locker room, possibly sometimes accidentally sharing, towels, that increases their risk for having infection because of their close contact, or even poor personal hygiene. Sometimes it can even be to shaving their body, or sharing different equipment. So basically, one of the more common infections that we see is we see a lot of staph, and this is MRSA. This is methicillin resistant Staph aureus. We usually try to treat those infections with different types of antibiotics. So, and with another thing that we also see in the outpatient setting with female athletes is what we call the female athlete triad. So this is basically also known as the relative energy deficiency. So with female athletes, there's particular condition where researchers show that there are certain female athletes that have this interesting set of manifestations of having like low energy. Sometimes they'll have menstrual irregularities. They can have osteoporosis, so those three things in term have been kind of grouped together and known as this female athlete triad. And usually with this particular condition, you have to have different multidisciplinary treatment teams come together to kind of create a effective plan for this patient, because there's certain things that are going on from their bones to their energy to psychological. So it's it's a very, very tough condition to treat, but if you have a good multidisciplinary team, patients have been shown to improve with these with the effective treatment. So, and in terms of different statements for treatment, so menstrual irregularities and low BMI increase the risk of stress fractures. And then you can also have functional hypothalamic amenorrhea that's diagnostic of this as well. Sometimes you can have athletes with one component of this, and they should be assessed if they have one component of this. And if the DEXA, which is like the bone scan screen, shows like a stress fracture, you can also know that they're possibly part of this female athlete triad. So the main thing that we want to make sure that we're doing is we're increasing their BMI, and then also making sure that we're supplementing them properly. And if they have an eating disorder or anything else that's making their issues worse, we're addressing those things. So that was the last slide. I want to say thank you to the virtual shadowing working group. This is my Instagram at Dr. OMD and my Facebook. I want to also thank the people who helped put this presentation together. Julian Johnson, the Wayne State medical student. And this is his Instagram if anybody wants to follow him as well. And then we also have the engineer, fitness expert here in Detroit, Ray Thomas. Also, he's an engineer for Ford. His IG is raysun at .5. And Dr. Katie Simmons from Summa Health System, the Acton Campus Family Medicine Program. And here's her Instagram. Really appreciate coming out here and presenting this topic to you, everybody. I hope everybody had a chance to learn something from this or even spark their interest in sports medicine. If anybody has any questions about, sports medicine or even the family medicine residency, I also even have my own terms of own product service where I help medical students and residents who need help with their applications for medical school or residency. They can feel free to reach out to me on my social media page. But it was a real pleasure having this chance to present to everybody. And right now we have a Q&A. If there's any other questions or comments anybody wants to make, feel free.
Casey, what a wonderful talk, and that's just terrific. And why don't we take a small number of questions? It's getting late, so go ahead, Elena.
Okay. One question we have is, when would you recommend family medicine for a sports injury versus referring out to a sports medicine specialist?
When I recommend is family medicine for sports medicine injury, rather than recommending a family medicine.
Sports.
Yeah, I mean, when would you refer to a particularly board certified sports medicine doc as opposed to, a family doc trying to handle the problem, and a bad ankle or a bad knee and so on?
Okay. Well, if I can kind of explain the difference between outpatient sports medicine physician and a family physician and the differences in. So a lot of the sports medicine physicians themselves are either certified in or are family physicians, but they're certified in sports medicine, or they're PM&R or orthopedics or even emergency medicine. So the main difference in terms of what we do in our family medicine clinic and when we choose to refer is like if there's a invasive treatment or procedure that we need to do or that requires maybe some sort of imaging, then that's a case where we refer that out to a sports medicine physician or even an orthopedic specialist. So for example, if you have a shoulder injury that's, you have chronic inflammation of the shoulder, you are, thinking about possibly getting some steroid injections in your shoulder, that usually is something that's going to be done by either, sports medicine specialists or even the PM&R or orthopedic specialists. So that's something that would be referred outwards because a lot of times that's done underneath the guide of ultrasounds or other imaging modalities. So that's something that would be referred out to. But if it's something like a minor sore knee or ankle injury, and sometimes a lot of family physicians have a broad spectrum of training experience, especially if they're, urgent care or even some of them that have gone to work in these more smaller rural towns and maybe had a chance to work in the ED. They might have a little bit more experience, but in general, unless they've had that experience, and I would recommend, anything that requires like a procedure, whether it be an injection or imaging, to be referred out to sports medicine physician. If something that needs to be done with like strength and conditioning or training or rehab, that also needs to be referred out as well. So yeah, that would be my recommendation.
Okay. And then I'll do one more question. Are patients with SRC supposed to also avoid looking at screens for the first 24 to 48 hours?
24 to 48. I mean, if it's something that's exacerbating their symptoms, I would highly recommend them to, avoid looking at a screen because, some research has shown that looking at screens has exacerbated some people's symptoms with SRC, whether it be a headache or dizziness. So if they can just rest and, try to do as little activity as possible within that 24 to 48 hour time frame, and then that would be more ideal. But if it's not really bothering them that much, then I mean, you could possibly make an exception for that patient.
Okay, well, I think that's all the questions we have tonight, unless Dr. Fowler, do you have any?
Hey, no, I don't think so. We're past 9 o'clock already. Casey, what a great talk. Thank you so much. And for a guy who's in, who's in training and still has got a long way to go, it's just astonishing to hear your amazing expertise. I would like everybody on the line, all of the folks out there, to please put thank you, Dr. O, into the chat so he can see that from you. Let's pound him with thank yous. Casey, take a look over in the chat, and I hope you see that you've got hundreds of grateful people who are expressing their sincere gratitude on you taking your time to come tonight. Well, folks, this is virtual shadowing, and we're glad you were here. I want to thank all the people who've made all the nice comments to us during the evening. We're gonna be here if you keep coming back, and we're looking forward to planning the next year as a few of our members go off to medical school, and we keep bringing on some new folks to help run this program. Again, I want to remind you that we will be sending out a note to all of you about the INSPIRE trial sponsored by the Centers for Disease Control to look at follow-up on people who've had COVID. It's an 18-month study. There's a little money involved for those that do take the survey. And so please look for that note in your email. We want to thank you all for coming. This is exciting for us to do this. Casey, thank you so much. God bless you. And I wish you all the best in your career as you move forward. So thank you, everybody, for coming. And on behalf of Elena and the whole working group team, we want to just say we're so pleased to have you here this evening. And we wish you a good evening and a good night. Thank you.